Hello, dear friends. Welcome to our today's case discussion. Our today's case is a endoscopic third ventriculostomy, acute hydrocephalus cases due to fourth ventricular obstruction by intracranial hematoma. This is Dr. Farhad Hussain Choudhury from Dhaka, Bangladesh. A 55 years old male presented with headache, vomiting, and altered level of consciousness. His GCS was 9/15 on admission. He was admitted in intensive care unit and CT scan was done immediately, where you can find there is a small hematoma in the fourth ventricle producing the obstructive hydrocephalus, and that caused the deteriorating level of consciousness to the patient. At the same time, CT angiogram was also done to exclude any vascular pathology. So, in this case, for ventricular hematoma with hydrocephalus associated with deteriorating level of consciousness, we have got options. Number one, ventriculoperitoneal shunt, external ventricular drainage, endoscopic third ventriculostomy, or hematoma evacuation. In this case, we decided to go for endoscopic third ventriculostomy. We did emergency endoscopic third ventriculostomy with the ventricular drain that was brought outside and kept close in the bandage for emergency use only. We introduced the ventriculoscope into the ventricle through the Cocker's point on the right side, and we can see the choroid plexus, then thalamostriate vein, septal vein, foramen of Monro. Through the foramen of Monro, we navigate the endoscope into the third ventricle, where you can see the mammillary body and the space in between the dorsum sella and mammillary body is bulged up and by the quadrifurcation of the basilar artery, and the space is completely occupied by the properator and branches of the basilar terminal part. One can say of the infundibular races. So here the pulsation can be seen through the third ventricular floor. With the help of the endoscope, we are searching for a safe place to make defenestration in the floor of the third ventricle, but everywhere there is pulsation of the terminal basilar artery and its branches. So we targeted a place on the right side of the floor of the third ventricle in between the mammillary body and dorsum sella, and lateral to the impression of the P1. Once again, one can see the infundibular races. rechecking the floor and assessing the targeted area. One can appreciate how the floor of the third ventricle is buzzed up by the pulsation of the basilar artery and its branches. So we think the targeted area is relatively safe to make a fenestration. The targeted area is in between dorsum sella and mammillary body on the right side, just lateral to the bifurcation of the basilar artery. Very careful fenestration made with the endoscopic ventriculostomy forceps. Some difficulty and extra force is needed to make a hole at the floor. So a hole is made with the fenestration forceps. Now we can see some bleeding from the fenestration site. So control this bleeding, we press the fenestration site and bleeding site with the tip of the endoscope. This is one of the way to control bleeding during endoscopic third ventriculostomy. Now the fenestration is widened with 2F Fogarty catheter balloon. Fogarty tip is passed through the fenestration and the balloon is inflated to enlarge the fenestration, but once again there is some bleeding from the fenestration side, so we are putting some pressure with the Fogarty catheter to stop the bleeding. This is another technique of controlling bleeding during endoscopic third ventriculostomy. Still some bleeding. We increase the irrigation and approaching the endoscopic tip to the fenestration to give some pressure at the bleeding site and also to look through the fenestration. This is a difficult case for endoscopic third ventriculostomy as the hydrocephalus develop acutely and the floor of the third ventricle is thick, difficult to perforate, and preoperatively from CT angiogram we can also see the fenestration site at the floor of the third ventricle is totally filled up with the basilar artery and it branches. So technically it is a very difficult case for endoscopic third ventriculostomy. So we are once again looking to the fenestration site. One can appreciate the flow from the ventricle to the subarachnoid space through the fenestration, and bleeding is now stopped. We put the gravity balloon once again, made the fenestration bigger. With the enlargement of the fenestration, one can see it is just lateral to the PO, basilar artery, and posterior artery on the right side, just lateral. There is CSA flow through the fenestration. This is an uncut and unedited video of endoscopic third ventriculostomy. So we decided to make another fenestration on the side of the previously done fenestration with the tip of the Fogarty catheter. Once again, there is some bleeding. Irrigation is increased. Some pressure over the fenestration with the help of the tip of the endoscope, and trying to peep through the fenestration. Once again, we pressed the Fogarty catheter tip, but one should keep in mind just under the fenestration there is a course of the third nerve on the right side. So through the fenestration we can see the branches of the basilar artery, the PCA and superior cerebellar artery, and some perforator can be seen clearly. Basilar cord bifurcation and perforators from the basilar artery. Once again, peeping to the fenestration, basilar cord bifurcation, and there is clear pulsation through the fenestration that indicates the CSF flow through the fenestration. Once again, looking through the floor of the third ventricle where multiple fenestration was made. So one can appreciate the disposition of the basilar artery and its branches just below the floor of the third ventricle. That makes the surgery very difficult and challenging. So after fenestration, we decided to put a ventricular catheter through the endoscope trap, and the catheter was kept closed, and the external end is put in the bandage, and it is actually put to drain CSF in emergency situation if there is blockade of the stoma at the floor of the third ventricle, then we can open it up. So after surgery, the patient recovered well from the anesthesia. He had got no third nerve palsy or any diabetes insipidus postoperatively. And on first postoperative day, his consciousness level improved and became 15 by 15. And CT scan on the first postoperative day showed there is decreased size of the ventricle that indicates situation improved over hydrocephalus, and there is ventricular catheter in situ. And CT scan was repeated on 4th postoperative day, showing the same picture of resoluting hydrocephalus, and the patient recovered well without any complication, and his EVD was removed on 5th postoperative day, and he was discharged on 6th postoperative day with advice for regular follow-up. Thank you.